Neurodevelopmental treatment, or NDT, is well established now as a very successful way of dealing with feeding problems in children who have cerebral palsy or other neurological disorders. Despite its proven effectiveness, however, NDT is not widely understood. The basic NDT course is 8 weeks long, expensive, and infrequently taught. At the same time, NDT techniques like jaw control and downward pressure on the tongue blade with a spoon and so on have become fairly well known, being presented in many texts, conferences, and workshops. But these well-known techniques in and of themselves are not always terribly effective, as we will show later in this program, and indeed, as many of you have already discovered from your own experience. What we want to show you, therefore, is not just the techniques themselves, but the rationale behind the techniques as well. Our aim is to present an approach to treatment based on NDT, the general context in which the particulars the therapist encounters are to be understood, the broad understanding that is essential for successful therapy. Now, the first principle of NDT is that we start with an understanding of normal oral motor development. We use the observed patterns of normal development as paradigms or models in 2 ways. First, to diagnose the nature of the feeding problem we have to deal with, and second, to direct us in our therapy. The normal infant starts with a set of reflexive oral movements. He then builds his oral motor skills upon these primitive behaviors in a well-defined sequence of development. Here, for example, is the primitive pattern called the suckle-swallow reflex. This familiar infant pattern involves an up and down movement of the jaw, combined with a forward and back or extension-retraction tongue movement. At first, tongue and jaw work together, more or less as a single unit. The development from this primitive suckle-swallow movement to the true suck is marked by an increasing dissociation of movement. First, the tongue remains with the jaw during the suckle and may protrude between the lips at the point of swallow. Later, the tongue rides up with the jaw, but remains briefly on the alveolar ridge while the jaw descends. This stage brings with it an important sensory impression for the child of the independence of tongue and jaw. In the final stage, there's an active tongue tip elevation at the point of swallow. This occurs only after the development of jaw stabilization. Let's look at the normal development of jaw movement. The reflexive pattern here, called phasic bite, is an up and down jaw movement in response to stimulation of the molar surface. The first development from this reflex is munching, which is a voluntary up and down movement of the jaw. In true chewing, there's also a lateral dimension to jaw movement. This development involves the acquisition of certain lingual skills. The tongue begins with what is called the transverse tongue reflex, a lateral movement of the tongue in response to stimulation of the side of the tongue. As tongue movement is refined, so is jaw movement. When the tongue is able to move food from the center to the side, jaw movement becomes diagonal rotary. And when the tongue can move food from one side to the other across midline, chewing reaches its final stage, which is circular rotary. Another aspect of development is that of graded jaw movement. This child is able to stabilize the jaw in a fully open position to receive the spoon. This extensor control is soon followed by the flexor control, needed to stabilize the jaw in a fully closed position, for biting down on a cookie, for example. Next, the child learns to stabilize the jaw in a partly open position for cup drinking, by biting down on the edge of the cup. This external jaw stabilization is an important step, involving, as it does, a balance between flexion and extension. For a more detailed analysis of normal oral motor development, there's an excellent resource, The Normal Acquisition of Oral Feeding Skills, Implications for Assessment and Treatment by Suzanne Evans Morris. But we have enough now to turn to our consideration of dysfunction and treatment. As I indicated before, the important thing here is our overall approach to the problem. This approach is based on a number of broad principles. The first of which is that abnormal behavior is to be viewed in relation to normal development. The therapist's first job is one of assessment. This entails a close inspection of the child's behavior to identify which elements of it are normal, which are primitive, and which are abnormal. Here, for example, we see a common problem of a primitive nature. Basically, this child is exhibiting a fairly normal sort of suckle-swallow pattern. Note in particular the exaggerated extension-retraction pattern of the tongue. In place of this tongue protrusion, the child should be developing, as you remember, the tongue tip elevation that is characteristic of a true suck. In this kind of case, we find that the simple technique of applying pressure under the chin or lower lip works to eliminate the primitive tongue protrusion and to facilitate the normal developmental pattern. When spoon feeding a child who exhibits a tongue protrusion like this, we have another good technique, that of applying pressure to the tongue blade with the bowl of the spoon. This child exhibits another problem of a primitive nature. Notice the up and down movement of her jaw on the cup. And here, you see how her mouth snaps shut on the spoon? What we see here is a lack of graded jaw movement. She can open and she can close, but she cannot achieve a balance in between. The normal infant, as we explained, first achieves this balance between flexion and extension by stabilizing his jaw on the rim of the cup. We use the familiar technique of jaw control in this kind of case to achieve the same result. And here is jaw control in a somewhat modified form, shown in the context of spoon feeding. In general, specific NDT techniques are most successful in primitive situations such as this. Here the child lacks development in some normal feeding skill. By assisting him in the performance of that particular skill, we help give him both the motor and the concomitant sensory experience that will help him to progress along normal developmental lines. The importance of the child's sensory experience in the assessment and treatment of oral motor dysfunction cannot be overemphasized. This is one of the broad principles most fundamental to our approach. All motor learning entails sensory learning. Normal motor development depends on normal sensory experience which it is easy to take for granted. Think for a moment of the tremendous learning opportunities that a child misses, for example, just by being unable to put his hands to his mouth. In addition, cerebral palsy and other neurological disorders are apt to impair in various ways the child's sensory feedback system. Any such aberrations in a child's sensory experience are bound to impact seriously on his attempts at motor learning. So whenever we see abnormal motor behavior, we must consider the behavior in the context of the sensory environment in which it occurs. What you are seeing here is not a tongue protrusion, as we saw before, but a tongue thrust. This is not a primitive, but an abnormal behavior. That is, one which does not appear at any time in normal development. Other common abnormal behaviors are tonic bite and lip and tongue retraction. Very often, these abnormal behaviors appear together in a whole pattern of movement. In this sequence, for example, notice the consistent pattern of tonic bite, lip retraction, tongue thrust, fisted hands, and tightness in the area of the mouth. This reinforces our point that when we encounter these abnormal behaviors, we have to consider them in a sensory context. What we are observing here, as we so often do, in cases involving some kind of neurological impairment, is a pattern of hypersensitivity. And any therapy which overlooks the sensory dimension of this child's problem is almost certainly doomed to failure. Here, for example, you see the therapist using the technique of jaw control in an attempt to inhibit tongue thrust. And you also see that she's not meeting with much success. This illustrates the error of trying to use NDT techniques outside of their proper context. Jaw control is great for dealing with a lack of jaw stabilization or graded jaw movement, but by itself, it's not going to be successful in a case like this. But successful therapy is not so elusive when you understand the real nature of the problem. Here, the therapist is not working on this child's tongue thrust or jaw thrust or tonic bite. She's dealing with the underlying hypersensitivity instead. This can involve manual stimulation of the oral area by the therapist, possibly with some vibration to reduce muscle tightness, or we may use the child's own hand in much the same way. Soft rubber toys can also be used. Remember, we're dealing with a whole pattern of retraction here. This pattern extends to the entire body, not just the mouth, and so should our therapy. Food can be introduced gradually by smearing something like applesauce on the child's hand or directly on her lips. Compared to traditional therapies, this may seem a rather roundabout approach, but time after time, its effectiveness has been proven. Here, we see an even more successful treatment of hypersensitivity. Notice the grading of stimulation. The object of the therapy is to keep challenging the sensory system without overloading it. Notice, too, the positioning of the child. We have more to say about this in a moment. Hyposensitivity is also prevalent among children with certain developmental disorders, Down syndrome for one. Here, our treatment calls for increasing sensory input in various ways, including the use of extracts, which produce a tingling sensation in the mouth as they quickly evaporate. But a caution is necessary here. Hyporeactivity is not the same as hyposensitivity. Before beginning a treatment program, the therapist should make certain that the low reactivity of the child really is hyposensitivity and not a sensory defensiveness masking an underlying hypersensitivity. Another fundamental consideration, which our approach emphasizes, involves positioning, posture, and tone. What happens in the mouth cannot be divorced from what happens in the rest of the body. And a child is hardly likely to develop a perfectly normal pattern of feeding if the rest of the body shows a gross pattern of extension or asymmetry or abnormal tone. In some cases, this may mean that treatment of oral motor dysfunction takes on a new dimension, to the extent that the development of feeding skills requires a certain degree of normal postural tone and proximal stability. This indeed is where therapy must start. Such therapy obviously takes a great deal of time, but at least it's time well spent. Whereas to take a child like this and try to sit him in a chair and physically manipulate his hand to his mouth is largely a waste of therapy time. In all cases, the therapist must be aware of the implications of the position used for feeding. Here are a couple of don'ts. Since this hypersensitive little girl keeps forcing food out of her mouth, it may seem natural to move her into this position. But now the food comes much too fast for her, And as you can see, the retraction pattern only gets worse. The feeder's comfort must be considered, but it cannot come at the child's expense. Here, the position of the therapist higher than the child forces her into an abnormal and undesirable feeding position, a position, which you notice, the child herself is fighting against. A position which forces the child to turn her head is equally undesirable. A midline position of the head, good proximal stability, face-to-face contact between feeder and child, as well as the comfort of both. These are the fundamentals of good positioning. But a position can be stable without being static. And for the therapist who takes an imaginative, innovative approach, the possibilities for dynamic positioning abound. Admittedly, there is a lot involved in this approach to therapy. It is necessary to make a careful assessment of the nature of the oral motor dysfunction based both on normal oral motor development and on the overall development of the child we are treating. Where we identify primitive patterns of normal development in the child, we can often build on these very successfully using certain special techniques. Where we are faced with abnormal behavior patterns, on the other hand, we look for abnormal sensory experience, including, very importantly, the proprioceptive experience of posture and positioning. In these cases, there's nothing approaching a simple solution. We must treat the complex underlying problems. This means creating a more normal sensory environment for the child and calls for intelligence and inventiveness on the part of the therapist, as well as a great deal of patience. And yet this approach to therapy, by letting us look at the child that is brought to us and see exactly what is happening and why, in the context of what should be happening, this approach offers by far the best avenue of success. For without this understanding, therapy can be very discouraging, so aimless and hopeless. With this understanding, it's still a big job, a long road to travel. But when you know where you're going and you know how to get there, I think it becomes positively enjoyable.
Patty cake, bake this man. They need a cake as fast as you can. Roll it and pat it, and mark it with the V. And put it in the oven for 3 and 4.